A 58-year-old female patient presented to the OPD with difficulty in chewing and sometimes biting her own tongue, and she has change in voice and difficulty in deglutition. With these complaints, she was evaluated with MRI brain plane and contrast, which revealed a giant foramen magnum meningioma that is encroaching the both vertebral arteries. Later, she was planned for surgery. The approach was far-lateral approach with mobilization of the vertebral artery and drilling of the condyle. She was placed in parkbench position, and the incision was taken retroauricularly, extending from occipital region to the neck. And the surgery was started with raising the skin flap, followed by raising the muscular plane, and we have started first with the mobilization of the vertebral artery. The C1 arch is identified, and the lateral part of the C1 arch where the foramen, where the vertebral artery enters the uh, foramen for vertebral artery has been identified. And first, initially, the vertebral artery below the foramen has been skeletonized. Later, the vertebral artery is followed, and we have deroofed the vertebral artery foramen over the C1 posterior arch, and the vertebral artery is completely mobilized, and the vertebral artery is followed till where it enters the dura, and into the brain. The mobilization of the vertebral artery has to be done very carefully without injuring the vertebral artery, as it may lead to vasospasm of the vertebral artery. Slowly, the adhesions are cut over the artery without causing any injury to the vessel. The adhesions are coagulated away from the artery without causing any heat injury to the vessel. With sharp dissection, all the adhesions are slowly cleared off, and the complete skeletonizing of the vertebral artery is achieved. Once the skeletal artery is skeletonized and its entry into the dura has been marked, and we slowly start for the next step, that is drilling of the bone. The bone is started drilling. We started drilling the bone in the suboccipital region, exposing the dura, and we encountered several visceral veins and over the bone, which are uh, stopped with the bleeding has been stopped with adequate bone wax application. Later, the condyle is identified, and we started drilling the condyle. Once the condyle drilling is being done, we can see many vessels that are there is a good amount of bleeding from the condyle. So adequate hemostasis with application of bone wax is necessary. Once the condyle has been drilled and adequate exposure of the dura has been done, the vertebral artery is you can see the vertebral artery pulsating, which is covered with a cotton patty, and the dura is open in the suboccipital region. Once the dura is opened, we identify the cisterna magna, and we drain the cisterna magna. Once the cisterna magna is drained, there is adequate space for operating, and the CSF has been let out. Once the CSF has been let out, the tension has been reduced, and we can see the brain pulsating. Here we can see the tumor. First appearance of the tumor can be seen here, which is very close to the brainstem. So adequate um, necessary steps are to be taken not to apply too much pressure on the brain. Here we simultaneously use neuromonitoring to identify the nerves. Once the tumor has been identified, the surface is coagulated, and the tumor is slowly started peeling it away from the brainstem, and we could get a good plane between the tumor and the brainstem. Once the arachnoid has been peeled off, we can identify the 12th nerve here, which is very close to the tumor, and some part of it is being encroached by the tumor. Under nerve monitoring, we have identified the trapezius nerve supplying to the trapezius, that is the spinal axillary nerve, and the 12th nerve has been identified with neuromonitoring. Once they are identified, they are pushed away from the tumor onto the brain, and we are doing a dissection between the tumor and the dural surface, undersurface of the tumor, between the dura and the tumor. We also take care not to apply any pressure over the brainstem. So all the pressure and all the work has to be done between the tumor and the dura. Here we can see the vertebral artery, first glimpse of the vertebral artery, that has been encroached by the tumor. That is, this is on the right side. Once the tumor, once the vertebral artery is identified, we slowly start debulking the tumor. As the tumor is very calcific and fibrous, the and CUSA and depredator could not be kept here and removed. So we slowly started removing the piece bit by bit. Here you can see the 12th nerve, and the first glimpse of the vertebral artery can be seen here. The 12th nerve is slowly dissected off the tumor, and it is pushed away from the tumor. That is a vertebral artery that is within the tumor. So we started coagulating the tumor bit by bit, and here again we are using the nerve monitoring to check for the 12th nerve. The 12th nerve is slightly adherent to the tumor, which is coagulated and cut. The tumor has been coagulated and cut, and 12th nerve is released away from the tumor. Once this is done, we can have a ample amount of space to operate onto the tumor. See, the vertebral artery can be seen being reflected away from the tumor here. That is the free part of the vertebral artery. And once that is done, we have good access to the tumor. Now the main process will be debulking of the tumor. As the tumor is very fibrous and it is very difficult to remove, and we have started removing it bit by bit, and the cautery has been kept at the lowest, and we are coagulating the tumor slowly. The tumor is being removed by in a piecemeal fashion with the use of dissector and tumor holding forceps, without damaging any of the neural structures or the arterial structures. So the tumor is slowly removed in a piecemeal fashion. This is the zoom in for focus of the tumor. We can see the blood oozing out from the tumor surface, and this has to be controlled with adequate hemostasis, that is between the tumor and the dural surface. Once the dural surface has been coagulated, we could get good hemostasis, and the field will be very clear. Here we are now moving into the base of the tumor and slowly removing the tumor bit by bit. Now we are about to enter to the opposite side of the tumor, and we are using a disc punch to remove the tumor bits that are very adherent to the dura. Now we could get a first glimpse of the vertebral artery on the opposite side. Once this chunk of tumor has been decoded, we will be encountering the vertebral artery on the opposite side. As the tumor is very calcific and very adherent to the dural surface, we have partially removed the tumor, and the rest of the tumor bed and the tumor is being coagulated. Using a dissector, the plane is being created between the tumor bed and the dura. And with every step, there is some amount of blood oozing, which is controlled with bipolar. Now we can see most of the tumor has been removed and we are onto the surface of the tumor, where there is a bit adherent tumor that is being coagulated for hemostasis. Once we confirm adequate hemostasis, now we will start closing the dura in a watertight fashion. And once this is completed, a drain has been kept and the bone and skin flap has been closed. Post-op MRI has been done, which revealed good decompression of the tumor with slight amount of tumor that is left adherent to the dura, which is very calcific. The rest of the brain has decompressed well.